everybody. Does anyone have any questions from last week? Can you hear me? Okay. If you don't mind leaving your cameras on, I would appreciate it. If not, then no problem. Any questions from last week or comments or feedback? Anyone? Bueller? All right, so tonight I want to change the pace a little bit, and we're going to take a little bit of a break from the super physiology, except in the context of the initial evaluation. I think that I realized last week that I want to put this in really clinical terms that, you can identify with very easily. And we can always go back in and out of physiology because the physiology is embedded in every single thing that we do. When you think about your initial evaluation with a patient, so what do you hope to gain out of an initial evaluation? So I want to kind of get an understanding of how do you find out you have a new patient? What do you do to prepare for that new patient? And what do you hope to gain from the evaluation, and what do you hope to offer to the patient from that evaluation?
Well, I think I want to find out what the patient expects from physical therapy, and also to find out what their baseline is now compared to what they want to be.
Their baseline physical condition, you mean? Okay.
Yes.
So what do you think most patients want to get out of physical therapy?
To feel better.
To feel better. But how you feel today can be based on so many different things, right? Like it could be based on, does my shoulder hurt today? It could be based on, did I get enough sleep last night? It could be based on, did I have a fight with my wife this morning on the way? And so patients have a lot of things that affect their ability to participate, not just in therapy, but in life. And the idea is that it's really important for us, and I think a lot of times we're taught that there has to be like this professional divide between, patients and clinicians, and we have to keep that line. And I used to believe that. And in some cases, it's excruciatingly, I said excruciatingly, which is a Freudian slip. I meant to say crucially important, but I said excruciating. But the idea is that it's always, important to start that way and kind of loosen things up. Like it's okay to loosen things up. I mean, ultimately, before we're clinicians, we're people, right? And one of the things, especially as we go to, a world where technology is king and queen and jack of, care, people want that personal touch. And it means getting to know them. Now, that doesn't mean, say to your patient, like, wow, I really got bombed last night, like me and Greg used to do. But it's like, the idea of, it's the idea of like really being able to relate to somebody and making them feel comfortable. So I'm just going to share my screen in a couple of minutes. What else do you hope to get? Like, what do you do to prepare for your initial evaluation? So as I understand it, I get a notice that there's a new patient. I get some forms that the patient fills out. Sometimes I've gotten test results. What do most people do? And I bet probably everybody doesn't do the same thing, but what do you like to do to prepare for your initial treatment?
I typically prep out the questions that I want to ask based on their intake, just to ask more about it, because I find that when people actually fill out the intake, it's very vague. So I just ask them in the specific order, just questions that I have regarding what they had already filled out, which just starts kind of with how you feel and open-ended, and then kind of lingers down into more of their past medical history to find out their prior level of function.
Did you say that patients say that the intake is vague, or you feel that what they put in is vague?
I feel like what they put in is vague.
How many people think what a patient puts into their initial intake is vague? Mary?
Sometimes.
Okay, sometimes, right? So I mean, there's a lot of reasons for that, right? Like a patient may not want to tell you everything. How many people trust their patients more than 50%? Nobody? None of you trust your patient more than 50%? All right. So 50% is not that much trust, right? Like, so how many people trust their patients more than 75%? Mary, you're very trusting.
And it's not so much about trusting that they're trying to be truthful. It's trusting, do they know what the facts are? And so many people do not know what body they live in.
Beautiful point. Love it. Like to me, I am always surprised when people walk up to me in the street and ask if I'm Brad Pitt, you know, but it happens and I've accepted it, but you're 100% right about that. And one of the things that we want to learn about patients is not just how good a historian I am, right? Like I'm not saying like, you're sneaky. I think you're going to try to deceive me, but we also get to know like what is this patient's ability to participate in their own care? What has been their ability in the past? What have been limitations to their ability? Like if a patient comes in and they only speak Mandarin and you don't speak Mandarin, well, we're going to have a situation here, and that happens, right? So part of what we have to do is we have to overcome barriers, and we have to figure out how are we going to most effectively communicate with this patient so that we get the maximum physical gain out of our therapy and we get the maximum benefit out of it, right? Because we don't want to waste our time. How many times do you hear a story of someone goes for therapy, and half the time was spent, talking to the patient, trying to figure out what's going on, trying to overcome a language barrier. There was a therapist that was my senior clinical instructor when I was a student, and her name was Kate Parkin. Okay. And I believe she's still probably at NYU. Okay. This woman, I watched her communication style with people. And whereas somebody like 10 other people could try to communicate with somebody and they won't hear them, they won't understand what they're saying, they won't know what they mean, they'll be turned off by the way they look or their body language or their voice. Kate had a way of communicating with people that somehow after 5 minutes they would figure out that they have the same cousin in Manitoba. And I studied her and I'd be like, how does this happen every time that she's able to communicate with people in exactly the way that they need to be communicated with? And I noticed that it's really something that is a conscious effort and it takes attention and it's not something that happens accidentally. So when it comes to communicating with a patient, there's really I view it as three types of communication. So there's the negative communication, which is like inappropriate behavior, cursing, inappropriate jokes, disrespect to the patient, basically all the things you hear coming out of our room, where we see patients. And that's obviously wrong, right? Like, obviously, we don't want to do something to turn our patients off. And sometimes it happens. Sometimes we meet somebody, sometimes it's our patient, and just somehow we smack right up against them, right? But you say, well, you know what? People come in, they're not feeling well. They're coming to a place for the first time. They don't, they're often used to rude or inappropriate behavior. They have insurance issues. And now with COVID, it's like magnify that times 100. And we really have to prepare for that by being prepared for anything that's going to come out of, come towards us. And, one of the things we used to do at the Pulmonary Center is we know people are going to come in, they may be grumpy, they may be in a bad mood, they may be unable to breathe. We want to kill them with kindness, right? Like, believe me, I like to be right, okay? But being right is not always going to be helpful to you in terms of, you don't want to power struggle with your patients. So we give it all up, okay? Right off the bat, we say, we're here for you. But you want to eliminate the negative behavior. Obviously, there's what I call fluffy behavior, fluffy communication. So fluffy communication, you hear it all day, every day. It's like, hey, nice weather we're having. How about those Mets? Did you hear what Trump says? That does nothing. Okay, that does nothing but fill time in a relationship or in a treatment, I would say. So for me, from the time a patient comes in to the time, like from the time I meet them for the first time, and in all the minutes that I'm working with them, I try to make it so that every piece of communication I have with them is building that relationship. Because you're right. When I ask how much do you trust your patients, it's number one, there is, how much do we know from a historical perspective? How much intellectually does the patient understand? How comfortable are they, in giving you the information? And also, sometimes people are writing on these forums online and you're like, I don't know who's going to be reading this. Maybe I won't tell them about this, that, or the other things, or I'll just wait till they get there. So there's that. And then we talk about positive therapeutic communication, which is all going to be enhancing, and I know I don't say this to insult anybody. I don't say this to assume that you guys don't know this already. I assume you do. But sometimes these things can get pushed to the back of our mind and we can become focused on a hip or a knee or a shoulder or a heart or, a respiratory rate. So when it comes to really, taking, having a good evaluation with a patient and really meeting their needs, communication is really the key. So I'm just going to share my screen for a couple of minutes, and then I want to go through an initial evaluation with you. And again, this is my initial evaluation. You don't have to do it the way that I do it. There's reasons why I do everything that's in my evaluation. The book that I use is for the most part in developing this in 1995 was, Bickley or Bates Guide to Patient Assessment. And it's a book that's written for mostly nursing, but it's a brilliant book. And it kind of takes you through everything that you might encounter during a patient, intervention. And it talks about all these various things. So let me just go through a couple of things quickly. So when we talk about the history and the physical exam, right? So they're very kind of intertwined. And the history we think of as being very cognitive and intellectual, and the physical exam is really very technical. But there are both intellectual and technical and psychomotor aspects of each. And it's important to continually kind of go back. And, commonly, really an overused phrase is like the forest and the trees. And like some people will always say, like, they can't see the forest from the trees. But to me, it's like the forest is we look at the patient, okay? And then we go in and we look, limb by limb, joint by joint, system by system. And then we come back and it's like a microscope that we have to just keep readjusting from, internal to external and keep coming back and challenging our own assumptions. Because when we see a patient, it's very easy to be like, well, you have knee pain, therefore you have osteoarthritis of your knee, or you have a torn meniscus, or you have a rotator cuff tear, or you have COPD, or you have asthma because you're wheezing. But we have to constantly assume that, not assume, but we have to at least take into account that we only have part of the picture. And, like a flight, a plane is only as safe as its last flight. A patient is only as safe as their last treatment. So keep that in mind. And a lot of times I think we get into the idea that we know this patient and therefore we don't have to take their vitals again because we took them last time, right? Oh, how's the patient's blood pressure? I took it last time. Somebody could be, 120 over 80 last time. They come in after, they're pissed off. We've messed up their schedule or something like that, or it's pouring and their Uber driver took them to the uptown branch instead of midtown branch. And those are things that we need to know, keeping in mind that a patient's condition is dynamic and is only going to be what we see for that day. Abnormalities. Okay, so here's something that's very important. Okay, when we're in school, we learn about different conditions. Like, for example, with Parkinson's disease, we learn about the masked facies. We learn about a shuffling gait pattern. We learn about, a pill rolling tremor in the hands. Don't memorize these things, okay? You can't memorize them. And a lot of times, especially when you're learning, or when you're new or you haven't seen a lot of patients of a certain type, you have to kind of memorize and think of these things, but there's nothing stopping you from looking it up. And it's also really important, almost like a court reporter, to be able to report what you see. And rather than go in and say, oh, you know what, I have this patient with Parkinson's disease, therefore I expect to see these things when I go in, just wait and be patient, okay? Best time to learn about an abnormality is when a patient is there with a problem, and then you're going to ask them these different questions. So again, health history, conversation with a purpose, okay? Communication, verbal and nonverbal. So let's talk first about nonverbal communication, okay? It's also very difficult now because we're all wearing masks, right? So if not for these Zoom meetings where I ask you to turn on your camera, I wouldn't know what half of you look like from the nose down. But the idea is that, you know, how we stand, what we're wearing, and don't get me wrong, I'm not the shining example of who looks the most professional, quite the opposite, but I'm in a different kind of point in my career than, you know, somebody who's just starting out. Whereas, like, you know, when I was just starting out, I was 20 years old and I was like in trouble every other day. I felt like I was in the principal's office every afternoon. And, you know, but you have to really present yourself in a way that's going to exude confidence and instill confidence in your patients. So another thing is that talking with patients has a lot of important differences between a normal conversation. So in a normal conversation, there should be give and take. Okay. It's the year 2021, so it gets harder to find that these days. Like, I'll be on the phone with somebody and I don't say anything and they're like, are you still there? Like, they think it's impossible that somebody could actually be listening. But we are responsible. Everything that we do should be, here I go, frozen again. No, all right, I'm gonna switch computers. I prepared myself this time. Hold on. All right, so I'm gonna go away from this, but ideally, our role is always going to be to meet our patients' needs in all conditions, and that doesn't mean that it's to. It doesn't mean. Let me just shut this computer. Sorry about that. This computer is a killer. All right, there we go. So I'm not screen sharing anymore, right? Okay, good. So let's start with this sheet that I've given you. And again, you know, I encourage each one of you, like, there's no perfect initial examination that's going to work for every single person. So I really encourage you to basically think about the types of patients you see and ask yourself, what works for me, what doesn't work for me, what works for this patient population. But essentially, if you go to the first page, so name, date, age, referring physician. I don't think anybody needs any coaching on that. But when we talk about CCHPI, we're talking about the chief complaint and the history of the present illness. So as I mentioned in previous lectures, the chief complaint is not always the first complaint. And the thing is that a lot of times patients' chief complaint, like, it seems like there should only be one thing. And often there is one thing. Somebody will come in with a very discrete and distinct problem, and that's easy to treat. But then as you get to know them more, you find out that there are multiple complaints. So what are the things that you guys hear most as a chief complaint? But before you even answer that, how do you start your initial consultation? So if I'm your patient, what's the first words that are going to come out of your mouth to me? And I'm just asking, there's no right or wrong answers to these questions. So if somebody is willing to share, take me through like the first 3 minutes of your initial consultation with a patient.
Mine's just easy. It's an introduction of myself,
Beth,
and
I know
then
you want to say something.
I will end up explaining what we're going to be doing
Michelle,
in PT.
I can't hear you.
Oh no.
Now I can hear you.
Okay, sorry, I didn't know. It didn't say I was muted. I'll introduce myself to start, and then I'll kind of go through what we will be doing in PT from history to objective to treatment, and then what they will finish the end with and what we plan on doing going forward.
So you're going to tell them all that, right? Okay, so where do you introduce yourself to the patient? Where do you usually, where does your evaluation start? Does that happen in the room, in the reception area?
Prior to this, it was in the room when they would walk in. Now, when they show up on the computer screen.
Okay, so you're doing telehealth only. Okay, got it. Okay, great. And how do you introduce yourself?
By saying my name and that I'm a PT and working for H&D, and then go from there.
What's your name?
Michelle Troiano.
That's what you say? You say my name is Michelle Troiano?
Say Michelle. I'm
Okay.
not as formal.
And I'm just kind of splitting hairs because these things send a message, right? So if you say my name is Dr. Troiano, that's different than saying hi, I'm Michelle, or hi, I'm Michelle Troiano, right? So hi, I'm Michelle, very casual. Hi, I'm Michelle Troiano. You know, not everybody introduces their name first and last. And hi, I'm Dr. Troiano is a very different message, right? How many people introduce themselves by first name only? Hi, I'm Mary, right? What if there's two Marys? How they know which one you are? How many people introduce first and last name? Okay, I'm Rob DeLillo. How many people introduce themselves Dr. Ettinger? Nobody? Okay, good. I don't either. I don't know. As physical therapists, I think it's awesome that we have a doctorate, but as physical therapists, like one thing I get accused of constantly is trying to pretend I'm a doctor. I'm not, you know, whatever, but you want to be sure that you're not going to give people that misconception. And certainly if somebody calls me Dr. Greenspan, I ask them to call me Noah. It just feels more mutual to me. And if you think about like relationships, like a patient's coming to a doctor or a therapist or a nurse or even a teacher and a student, a policeman and a criminal, a police officer and a criminal, there's different levels of status, right? And when a patient comes to us, we by default have the higher status. The patient needs us. They're not coming to us because we need them, or we need them in different ways, right? We need them in different ways, but the patient is going to be at a disadvantage from a status perspective. And what I want to do is I want to minimize that as much as possible. So there's going to be things that will make that status difference greater and things that are going to make that status difference lesser. And, you know, like if you're confident, like you should feel comfortable having mutuality with patients. And you know, that's how you're going to get the most openness from the patient. What's the first question you're going to ask the patient?
I asked them what they'd like to be called.
Great question. Okay. So that's a good way of doing it too, right? One, and the other thing is I usually start with Mr. or Mrs. It depends on the setting, of course. But another great communicator was my old mentor, Dr. Horatio Pineda, and he was old school. Like he would say, ma'am, yes, sir. Patients love it. Okay. Old school patients love that stuff. The old, you know, the people that were like that are in their 80s and 90s now, they love it because it shows respect. Now, if you say, please call me Steve, and I keep calling you by your last name, that's not showing respect. So asking, what do you prefer to be called? Would you like me to call you by your first name, by your last name? All these things make a difference because they plant seeds in the patient's head, right? These are all subliminal type of things that you may not realize it, but these are the things that when that patient goes home and talks to their family about how their first treatment was, they're going to say, what do you want them to say about it? They were nice, they were knowledgeable, they were kind, they were considerate, they were compassionate, they were respectful. They asked me what I want to be called, as opposed to coming in and saying like, hey, Greg, how you doing? Like, or like people who come in, see my grandmother, and they'd be like, hey, Peppy. And I'd be like, Peppy, you're like 20 years old. Like, you know, not that she wouldn't say to them, like, by the way, her name was Peppy. They weren't calling her. Her name was Peppy. So she was Peppy, but her name was Peppy. But like, you know, it's the thing is that once you go over the line, it's very difficult to come back from the line. So to me, I'll always start at the beginning with the most respect, and you can always let it down. And you never let down the respect, but you could let down the formality of it. So, in terms of chief complaint in the history of present illness, I will start by asking a patient, why are you here? Okay. And that's what, if you notice, and I alluded to this last time, but essentially, in terms of getting information from my patient, there's three separate parts where I'm getting information from them. So it's CCHPI, medication systems review. So if I were to do any one of those alone, I could probably figure out parts of the other ones, right? Because if you know what medications your patient's on, then you're going to know some of their medical history. If you know your patient's chief complaint and the history of their present illness, you will probably be able to guess some of the medications that they're on, or, at least classes of medications, if you understand the prescribing patterns and what people take for different things. And then the systems review is kind of the glue that puts it all together. So chief complaint and HBI is essentially what brings you in here. And then as far as this episode goes, when did it start and what happened in between that initial onset of this episode and today? Now there's everything before that, okay? But that's not the history of the present illness. That's the past medical history. They're both important. So when I see patients, the overwhelming things that I hear most often are shortness of breath and I can't walk. And those two things usually occur with subway stairs, walking uphill, running for the bus. I could recycle some of my old jokes like the New York City Pulmonary Triathlon. But those are the things that I hear over and over again with cardiopulmonary patients. And the thing about, symptoms is that some symptoms are going to be extremely specific and some are going to be very non-specific. And when somebody comes in with a non-specific symptom like chest pain, it's specific in that we know what it is, but there are multiple things that can cause chest pain. Shortness of breath, it's specific, we know what it is, but there's many things that can cause it. Activity intolerance, pain. We have to just, keep in mind, again, if you think about House MD, like we got to look at all the possibilities of what those things can be and at least give them consideration. And trust me, when patients come in, they're not always properly diagnosed. And when it comes to COVID, that's a whole other ball game. So, when it comes to cardiopulmonary disease, there are things we know. There's a lot that we know. There's a general prediction of things we could do. And, again, between kind of the neck and the belt, you have a lot of systems crunched into our thoracic cavity and our abdominal cavity. And sometimes abdominal discomfort can affect and go up into the chest. Sometimes respiratory discomfort, or, as just one example, hyperinflated lungs, right? Hyperinflated lungs can push down, make you short of breath, but also affect digestion in that it could make you short of breath every time you eat and affect your ability to get proper nutrition. So keep in mind that the first complaint is not always the chief complaint and not always the most significant complaint. And often patients will come in with multiple complaints that could make the argument of being chief complaint. So don't always rule that out. And a good question that I ask people a lot of times is, so someone will come in, they say, you know what, I haven't been able to walk over the last several months. We say, well, why not? I have a bum hip. Okay, what else? I get short of breath. I have no wind, right? Or I have no endurance. And, again, you have to ask yourself, well, this patient's got arthritis. Okay, so what is it? Is it the pain in the hip that stopped them from doing the exercise, that deconditioned their, not just their muscular system, but also their cardiopulmonary system, their endocrine system, their autonomic nervous system, because all these things become less efficient. Your body gets good at doing what you ask it to do. So if you ask it to sit on the couch, flip the remote, eat potato chips, it gets very good at doing that, and it makes adaptations to it. So a lot of times, patients, a good question to ask people is, what is it that's preventing you from doing this? So is it the shortness of breath, or is it the chest pain? Sometimes they say, well, it's both. They come on at the same time. Is it the back pain or the shortness of breath? It's both. They come on at the same time. When you're exercising with people, and Rob had an interesting patient recently where, the patient was doing balance stuff, And we say, well, what is it? Why is this patient not able to balance properly? Is it strength? Is it that when they bend over, they get short of breath? Are there other factors that come into play here? And a question that you asked me, what are you most aware of now? Because you can have hip pain and back pain and chest pain. But the thing is, what is the first limiting factor? Because that's going to be what stops them first. Same thing with history of present illness. And I spoke last time about OPQRSTI, and that's a great way to kind of describe any symptom. And it could be back pain, hip pain, neck pain, chest pain, shortness of breath, onset. O is onset. So what were you doing when this began? Or what is it that elicits, how did this begin for you? Well, I was shoveling snow. Next thing I know, I couldn't breathe. I was out in the snow and all of a sudden my airways tightened up, right? So when we think about the airways, right, like a lot of people think that the airways are not something we can impact, right? Or your blood vessels are not something that we can impact, or weather, right? Like if we think about cold weather, somebody out shoveling snow, which is a pretty vigorous exercise, right? It's a full body exercise. We have the cold. So if you have a pulmonary patient, somebody with asthma or something like that, it's going to constrict the airways, right? We have smooth muscle that lines the airways. And a lot of times people say, I'm terrible in the cold weather because they go out. And in the same way that, your biceps or your hamstrings get tight in the cold weather, your airways can also get tight. And so somebody comes out, airways tighten up. Now they're working harder to breathe. The other thing is that when you go out in the cold, the blood vessels will also constrict. So if you remember what we were talking about last time, the left ventricle is going to pump out. If there's increased resistance, right, increased constriction, then we're going to have an increase in blood pressure and an increased workload on the heart. So all these things can come into play. And then we have the anginal equivalents, which are things that don't seem like the classic left-sided substernal chest pain with radiation down the left arm, but they're more like shortness of breath or neck discomfort or throat discomfort or jaw discomfort. And so it's really important to ask patients for a very vivid description of what's going on when they're actually getting into trouble, and say, so let me make sure I understand what you're saying to me. Tell me what happens. So I start shoveling. Okay, you start shoveling. Do you get short of breath right away? No, I'm usually okay for the first 5 minutes. And then what? Then my airways get tighter and tighter, or my chest gets more and more pressure, or my arms get tired, and then I have to stop because I'm fatigued. But you see, there's a lot of different things that can come into play with the same activity. And when somebody comes in, we assume it's musculoskeletal because of the nature of the practice. And sometimes it is, often it probably is, but we should at least keep in mind that there are other things. And as I said the first time we spoke, how great would it be if you get your patient's problems, musculoskeletal problems, treated so well that now they're able to actually do the activity that elicits other symptoms? Not to say we want to elicit other symptoms, but respiratory symptoms may not show up because your patient's back pain is what prevents them from climbing the stairs, or their hip pain or their knee pain. Their cardiac symptoms may not show up because they have COPD and they get short of breath before they reach any hemodynamic endpoint. And when we spoke about being able to trust your patient, I also asked you, how much do you trust the chart, right? So, we go to different places. We know, not everybody is as smart as everybody else. Not everybody's as experienced as everybody else. Not everybody is as diligent or attentive as everybody else. And, for me, I'm like Reagan. I trust but verify, right? So it's like it's the only way I'm like Reagan. But it's the idea of, what, I know this guy. Like, we know, like, as we work in the city, we get to meet to know a lot of the doctors, right? How many people know some doctors that they would recommend to every patient, A+ doctors? Raise your hand. All right. Hopefully everybody's raising their hand for this. You have to know some. How many people know doctors that you wouldn't send anybody to? Right. So we have patients. I mean, we have patients that, or we have doctors that send us a ton of patients. We never send them any patients, right? And they ask us about that. Well, it's an awkward conversation, okay? But the idea is that your history is only going to be as good as the person taking it and the person reporting it. So while I may look at what the patient sends to me, and it's kind of annoying to patients because they say to me, well, why are you asking me these questions? I filled out all these questions are online already, right? And I don't tell them that it's because I forgot that all that stuff is online in the computer already. No, I tell them it's because I want to know. I want to hear it from them. I want to make sure almost minute by minute, day by day, that we're not missing anything and that I understand everything that that patient wants me to know. Um, any questions or comments so far? I know this stuff sometimes seems obvious, but if you watch different people practice, okay, if we ask about this, people say, yeah, of course, it's important to get a great idea of the patient's, history and their symptoms and what's really impacting their lives. But then when we watch other people work, and I don't mean at H&D because that would never happen there, but we know that not everybody's doing this every time, or sometimes we feel better than others, right? Sometimes we're at our best. Sometimes we had a crappy day too coming in the morning, right? Not just the patient. Sometimes we don't feel our best, and we're going to get through it, and we get the basics, but we're not at our best. It's important to push yourself every single time, because even though the patient is one of 1,000 patients for us, we are one of one for them, right? So we're their physical therapist. They're counting on us to be on, right? And it doesn't matter how your day is going. And I know that's easier said than done, but the more you practice different things and the more you develop your own routine, the less chance you're going to have of missing things. And even when you're having a bad day, your mind can take you through these things. Like even when I study a lot. I study at least 10 minutes a day. And it doesn't sound like that much, but it's enough to kind of get me to where like my wheels are very well lubricated. And like I can say BSI, scene safety, MOI, NOI, and it's like I could be doing something, and I try to challenge myself in different situations so that it's not just like only if the room is prepared perfectly can I get through this evaluation perfectly. I want to challenge myself to be prepared for every situation. How many people would rate their knowledge of medications that they see? Think about the top 20 medications that you see. And I'm using a generic top 20 because each of us, depending on the patients we see, will see different medication lists, right? So if you had to make a list of the top 20 medications that you see from your patients, how many people rate their own knowledge as 5 out of 10 or less? So, Tom, you think that of the medications that your patients bring to you, you know less than 50% of them?
Um, Probably somewhere around 50%, but I have to look up a lot of stuff.
Okay. How many people think they're at 50% of what they see? 60%, 70%, 80%, 90%. So I'm assuming the rest of you are 100%. All right. So would we say that the average is 50%? Is that fair, or somewhere between 40 and 60%? Okay. Does anyone see a problem with that?
Yeah.
Okay. Lecture's over for tonight. Go study the meds. Greg, I got lucky the other day. Okay. I don't want you to think this happens to me all the time, but remember the other day when we were talking about patient and I said ProScar, and like,
Yes.
let me tell you something. I did get lucky. Okay. But I got lucky because I study medications, right? And the idea is I like to play match game. I feel like the $25,000 pyramid, if ever there was a game for me, that was my game. I feel like I could have definitely won $25,000 every time. And I love to be able to finish patient sentences when they're talking to me, not to cut them off, but when they say something like, I take lists, and they say, and because I know their medications or because they've told me some of their medical history, I can know this. And the other thing is that particularly as it relates to respiratory medications and the inhalers, there's like, what happens is a lot of times patients go home and they go to the doctor, they get a prescription. They go out with 3 pieces of paper. They come home, they have an egg, a disc, and a pump. They don't know that there's differences between them. They don't know that there's different medications in each one. They don't know that the medications do things differently or do different things. And if you can educate the patient about that in the first time that you see them, you've done them a huge service. Because how many times have you heard a patient say something like, yeah, the doctor gave me this, but I don't think it's doing anything for me? Sound familiar? Yeah, you hear that all the time, right? And especially with respiratory medications, because one of the ironies about respiratory medications is that for the patient population that has the least coordination of breathing, every single device requires you to have really good coordination of breathing in order to get the medication where you want it. Same thing with, cardiovascular drugs, right? Like there's a big difference. Just think of it like this. If I take my blood pressure medication, and I'm going to just use a scale of 1 to 10. I wake up, my blood pressure is 5, right? I take my medication, it brings it down to 1. Now I get stressed and I go up to 6, right? As opposed to if I take my medication at night, I wake up at 5, I go to 10 during the day, and now I take my medication, it brings me back to 5. You see the difference? So by you having an understanding of what the medications are, how they work, what they do, what the physiologic mechanism of them is, same thing with like the rescue inhaler. And I'm happy to talk about any other medications that you guys want to talk about, but just as an example, the rescue inhaler, like when you are, drowning and, you're trying to reach the lifeboat or the raft, that's not the time to try to work on your stroke, right? And the idea is for most patients, when they're walking in the street, and a lot of patients don't walk because they're afraid of their back pain, they're afraid of their knee pain, they're afraid their legs going to give out, they're afraid they're going to get so short of breath that they're just going to keel over, right? There's like Fred Sanford, they say Elizabeth is the big one. And if you're afraid that if you go out and take a walk to the grocery store, you're going to keel over, you're not going to the grocery store, right? It's like if you don't know how to swim, you're not going in the deep end. And so by knowing these things and going over these emergency procedures and also going over these preventive procedures, like, do you want to take your pain meds before you exercise? Is that a benefit? Sometimes it is, sometimes it's not, right? Sometimes it can be detrimental if you hide the pain, if you mask the pain, or if you overtake it. But, like as an example with your rescue medication, again, same thing as blood pressure. If I wake up and my breathing is a 5, okay, which is, average, I take my rescue inhaler 15 minutes before I go out, and that brings me down to a 1. And then I go out and the air clenches my airways. Well, guess what? Now I'm back at 5, but it's not a code red emergency. And trust me, when you listen to people talk, even clinicians often don't know about the medications. And we proved that tonight. Like, look how many clinicians are here and how many people have 5 years of experience or more? 10, 15. So, I don't say this as a criticism, but if you've been treating the same patient population for 15 years, it's in your best interest and your patient's best interest to get the medications, right? And to understand what they do, what the mechanism is, because how many times have we seen a patient who gets on a medication and then they have a side effect that, oh, they're given blood pressure medication and then they pass out and now they have a broken hip. These things happen. So here's a simple way of doing it. And again, I look around this room and everybody probably has a slightly different, like Justin's patients probably have a very different, set of medications than Tom or Rob or Greg, right? But the simplest way to do it is start to make a list. Start to take the list and put it in classes and say, okay, I may not know exactly what this, but I know what class it's in. I know it's a beta blocker. I know it's a calcium channel blocker. And I know that these things, and if you did that for 20 patients, right? Like if you did that for 20 80-year-olds, you'd find the same medications coming up again and again and again and again. and you will know all the medications that are a combination long-acting bronchodilator and steroid. And you will know all the medications because pain medications work in different ways, right? I don't know a whole lot about orthopedic pain medications, but I'm sure there's different mechanisms, and those mechanisms can also affect physiology. So looking around the room, this was good, a moment of confessional. Okay. I think everybody, I challenge you to take the next 20 patients, just look at the medications and start building up a little Excel spreadsheet. And I guarantee you, you're not going to see in the next 20 patients more than 50 medications, right? So after you've done that, make yourself some cards, right? Say, okay, this is lisinopril. It's an ACE inhibitor. It lowers blood pressure by preventing angiotensin 1 from becoming angiotensin 2. Boom. And now when your patient starts talking to you, and you can say to them, do you know what this is for? Do you know why you take this? Right? Like steroids, right? Like patients expect that a steroid is going to be instantaneous. Steroids reduce inflammation. It doesn't happen immediately. So by knowing these things and having a really good handle on them, when I say impress my patient, like I'm not trying to impress my patient in the sense that like I don't want the patient to be like, oh, you're so great. It's nice when patients say that, but the idea is you want your patient to be confident in you. And the more your patient has confidence in you, how many people have ever heard a patient say, this is the most thorough evaluation I've ever had, or I've learned more from you than I have in the last 10 years with my doctors, right? When you hear something like that, it means A, someone's doing something wrong, but you're doing something right. Okay. And trust me, when you call doctors and you say, hey, by the way, I don't know if you know this, but your patient, blah, 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 right? That's how you build community. And that's how you get referrals. Okay. I don't know what our list is up to now, but like we have like 75 patients on the cardiopulmonary referral list. Okay. We got 2 practices waiting to just spring up. And it's because over 22 years, people trust us. And the more you communicate, a lot of times as physical therapists, we worry there's 2 sides of it, right? Like I know physical therapists who, if it were legal, they'd be cutting the patients open and repairing their coronary arteries in the gym. Okay. But there's also physical therapists who we feel like, oh, we're just a physical therapist, or you know what, the doctors don't want to hear from. They do want to hear from us. Okay. And we have tremendously valuable information that doctors will never, ever get from their patient, right? Why? Because a stress test is not a normal situation. It's like you say, okay, take this cheetah. Let's see how the cheetah does with a hula hoop, right? It's totally unnatural for the cheetah. Now, if it were elephant, that would be a different story altogether. But the idea is that we see patients in exactly the positions and exactly the activities that challenge them in the same way that brought them here. And doctors won't see that. For what we do, we monitor every patient and we get to see things under the exact conditions that cause people shortness of breath, that cause people, chest discomfort and things like that. So keep that in mind. Communication and community is the key to great patient care. I am not a fan of direct access, okay? And it's not because I don't trust myself, it's because I don't trust other people, okay? Yes, I have personality issues, okay? But the idea is that why do we have to have direct access, right? Like, why do I want to be responsible for diagnosing, somebody's back pain that turns out to be a gallstone or a ruptured appendix or something like that? But to know that we have a place on the team and we're able to provide information that is unattainable anywhere else is very valuable to everybody. Any questions about the medication? So if there's one thing I've learned tonight, one takeaway message, start paying attention to the medications. They have these nurses drug guides. We use them all the time. But eventually, if you keep opening it up, keep opening it up, you're not going to have to open it up anymore. Okay. And trust me, a patient is impressed if you know the medications, but they're also impressed if you take the time to look up the medication, right? Because how many of us are guilty of this? So what you take, you take bisoprolol, and you go, and you're in your mind, you're like, what the hell is that, right? I mean, we've all been guilty of it. Like we've all probably been on the other end of it, like where we're telling a doctor something and we're like, this guy has no idea what I'm talking about, right? It's a bad spot for everybody to be in because patients expect that when they tell you something, that you're going to remember it and that you know what you're talking about. And if you're just writing things down to fill out the chart, you're doing everybody a disservice, mostly you, because what you're going to realize is that when you understand the physiology and you understand how the medications work, that you're not just observer to the physiology, you can actually impact it. And that is why we are having the success that we're having with COVID patients, because we've always believed that. We've always believed you can affect physiology and affect, the autonomic nervous system. All right, any questions or comments so far? So we covered chief complaint, HPI, medication. So now with medications, okay, that should allow you to start filling out the systems review, right? Because if a patient says, I take metformin, we know that they have what?
Diabetes 2.
Diabetes type 2, right? So patient says, I take metformin, I'm also going to go down and check diabetes on my sheet. Or if a patient says, I take, Nexium, we know they have GERD. I saw Tom say GERD. But those are simple examples. And trust me, there's a medication commercial on every 5 minutes anyway. Patients expect you to know these things. But again, when you start to understand how these things work, and trust me, I'm not saying this to you guys like you were just born yesterday. I know you weren't, and I know you guys are very experienced, and I have a lot of respect for this team. But if everybody here after 15 or 20 years is saying we only know 50% of the medications, would you be happy if you took your parent to a therapist or any clinician and they only knew 50% of the medications that they were taking? How could you expect them to make decisions that are going to be most effective for them, right? It's like Van Gogh only knows half the colors. So it's like, it's really to your advantage. That's the single biggest lesson I would take away from tonight, and start getting the hang of it. And we can even, what we could do? We could start a team spreadsheet, right? And if it's already there, let's put it up and let's catalog it so that we have now a practice thing. Because guess what? We could get a book that has 2 billion medications, but I bet if we did this for a month, we'd have the medications that are most seen in H&D. And I bet that's also a study. I bet that's also to say 20 most common meds by patients in New York City. And that's something publishable that we could all of a sudden say, and now we have this guide. And now instead of memorizing 2 million medications, we can memorize the top 20. And then you're there pretty much. It's going to go a long way. Systems review. Neuro, okay? So neuro to you might be different than neuro to me. And keep in mind that this is a rough guide. But when I talk about neuro, what I say to a patient is, do you have any neurologic problems, right? Language is very important, right? How many people, if you think about your grandfather or your grandmother, right? How many people think that their grandfather or grandmother would know what you mean when you say neurological problems? Okay, Allison, 1, right? I don't know if I don't think my grandmother would. I don't know. But the key is, I'll say, do you have any neurological problems? Because I want to give the professional way of asking the question by system, so that I'm also educating at the same time that I'm ascertaining information from somebody. So I'll say, by that, I mean, have you ever passed out? And this is, we're going across the top row now. Have you ever passed out? Dizziness, stroke, seizure, right? Those are the big ones, right? And then if somebody says yes or no to any of these things, then we go in deeper. So we take a first overview. So everybody knows what syncope is, right? It means passing out. And we know that there are dozens, if not hundreds of reasons why somebody can pass out, right? Everybody give me one reason. Go around in a circle. Give me one reason why somebody might pass out.
Low blood pressure.
Low blood pressure. Everyone's like, keep still in mind. What?
Anxiety. My son just passed out when he
could do it.
heard he needed
Right?
surgery. Yeah.
Anxiety. What else?
Pain.
Pain. And I heard arrhythmia. What's that?
Shortness of breath. SLB, shortness of breath.
Shortness of breath. What else?
Getting shocking news.
Shocking news. Shock, right? What else?
Blood loss.
Blood loss. That's also, I would consider that a different kind of shock, right? So going into shock. What else?
Vasovagal response.
Vasovagal response. What else?
Seizure.
Seizure. What else?
Low blood sugar.
Low blood sugar. Good one. I wouldn't say.
Low blood sugar.
What? What?
No, you got it.
Olivia, I'm buying you a new microphone for Christmas. What else?
Orthostatic hypotension,
Orthostatic hypotension. Okay, what else? Give me 3 more.
trauma,
Trauma. Yep. 2 more.
I'll give you one, anemia.
Anemia. Good. Don't sound so threatening when you say that. What else?
Panic attack.
What's that?
Panic attack. Panic attack.
Panic attack. Okay, so we had anxiety. We'll say panic attack. What else?
Seizure.
Seizure we had. What else?
Oh,
One
yeah.
more. Give me one more really good one.
Traumatic brain injury.
TBI. Okay, that's good. We had trauma, but I'll take it. So now I want to just point out one thing, okay? I want you to circle on your sheet. We're going to do this like bingo. If you have syncope on your sheet, circle it, right? So my point in telling you this is that look at all those things, and we've done the first one, right? We asked about one thing. Have you ever passed out? And if the answer to that is yes, it could be, did you ever have a traumatic brain injury? Do you have low blood sugar? Did you have a seizure? Was it a traumatic event, right? Because somebody could say, oh yeah, you know what? I was in a car accident and I smashed my head on the front windshield. Low blood sugar. You know what? I was running in a race and it was a hot day and I miscalculated how much fluid and glucose I should have. A seizure. You know what? It was a hot day. My electrolytes were way off. I had a seizure. Trauma. You know what? I had a home invasion and somebody hit me on the head with a bat. Low blood pressure. I forgot to drink all day and I have been avoiding salt, or my doctor gave me a beta blocker and an ACE inhibitor and this, and I didn't know that I was supposed to stop one and the other. And that's tied to orthostatic hypotension, right? And that's tied to blood loss, because blood loss will certainly reduce volume, and vasovagal is tied to all these things, and arrhythmia is tied to all these things, and pain is tied to all these things, right? Think about pain. Think about somebody in excruciating pain. What do you think system is driving that? The sympathetic nervous system, right? Fight or flight. They're in excruciating pain. Adrenaline's coming out. Heart is beating so fast that it might explode, and the body says, we better protect ourselves, right? We better protect ourselves by making this person pass out before they do some injury to themselves. So my point in telling you this is that there's a million different considerations. And with each thing, there's kind of a decision tree. And you go, well, do you have this? Do you do this? Do you do this? Everyone forgot drinking, right? That's another reason you could pass out. Drug overdose, right? That's another reason you can pass out. Bee sting, anaphylaxis is another reason you can pass out. Snake bite, another reason. Poisoning, another reason. So the point is that for each one of these things, there's a backstory. And so this is kind of like the intro, Match.com. Have you ever been in prison? That's the intro question. What for? How long did you do? That's where we get deeper. And each one of these things can go deeper and deeper and deeper. Dizziness, right? So if I wanted to say, Dizziness, right? How many patients report dizziness? How many people have had a patient in the last month that reports dizziness or lightheadedness? So if I were to say why, right? It could be that they've had a traumatic brain injury, right? It could be that they have low blood sugar. It could be that they had a trauma. It could be that they have low blood pressure or hypertension. It could be that they're anxious and that makes them dizzy. It could be that they're in pain and that makes them dizzy. It could be that they have an arrhythmia and they have these supraventricular tachycardias and there's no filling time like we talked about last week. And now we see a drop in blood pressure, right? Shortness of breath could also make you dizzy, right? Shock can make you dizzy. Blood loss can make you dizzy. Vasovagal can make you dizzy. Orthostatic, anemia, all these things can make you dizzy. So my point in telling you this goes hand in hand with risk stratification, right? How many times does a patient say, oh, you know what? I'm feeling a little lightheaded, and we go, and we don't do anything about it, right? We go, oh, okay, why don't you have a seat for a second? Okay, would you like some water? Okay, why don't you have some Gatorade? Oh, do you want a lifesaver? Right? But then what do we do about it? Or a patient goes to a doctor. It's not just us. Patient goes to a doctor. I'm lightheaded. Oh, well, why don't you try drinking too much water? I mean, what? Not too much. Why don't you try drinking more water? Right? But what if that patient gets lightheaded and we don't take it seriously? And then that patient walks out and they're on the bus and they can't get a seat. So they're standing for 20 minutes and they have orthostatic hypotension. They're getting more and more and more kind of lower blood pressures. And then they pass out. And now they have a head trauma and a broken hip. These things happen, right? So the idea is when you hear something like this, a lot of times physical therapists think, well, this isn't my place, right? But whose place is it, right? I mean, it's whoever is there, like as health professionals, as first responders, as people who actually have a clue about things that are going on. If a patient comes to us and reports something to us, then we at least have, if we don't know what to do about it, we at least have a responsibility to pass that information on or to at least start to observe it. So I don't call a doctor every time a patient tells me, oh, I feel a little bit lightheaded, or we stop the treadmill, people get lightheaded, it happens. But if we, now is where we start to bring in vital signs, right? Because if we're taking vital signs in these way, patient says, I've had syncopal episodes or I've had pre-syncopal episodes, right? Pre-syncopal episodes is well, I feel like I'm gonna pass out, but I sat down and then I felt better, right? Because maybe your blood pressure is dropping, but you sat down and put your feet up and that was enough to kind of, to do it. But by getting these baseline data, or if we know our patient had syncope twice over the summertime, then I want to make sure that that patient's not going to have syncope while I have them, walking in the gym or standing on a balance board or something like that. Stroke is a little more obvious, right? People usually know if they've had a stroke, and then we want to know, what are your residuals? Seizures, also a little more obvious. We hope that somebody's going to be pretty well controlled seizure wise. And then neuropathy can mean anything, right? So we think about peripheral neuropathy, which, we could say are paresthesias, numbness, tingling, pins and needles, pain, things like that. And incidentally, all of these things when it comes to COVID are in the forefront of all of this, right? So autonomic dysfunction, dysautonomia, all these types of things are on the table. Not for every patient, but they're there. And a lot of what makes COVID so confusing is that patients report symptoms that in the normal situation point right at a cardiac problem, but all their cardiac tests come back normal. Or something that points at a respiratory problem, but all their pulmonary tests come back normal. Or points at a brain issue, but their MRI and the CAT scan of their brain comes back normal. So then what? Then we have to rely on other pieces of information. Any questions about neuro? Comments? Patients you want to talk about? Does this sound familiar? Are these things that how many people? So let's say neurologic dysfunction. The patient comes, they're there for low back pain, but they also say, you know what? I often feel like I'm going to pass out. How many people on a scale of 1 to 10, put up your hands, how comfortable would you feel dealing with that? I often feel like I'm going to pass out. Or what would you do? Patient comes in, I often feel like I'm going to pass out. What are you going to ask them? What are some
I would ask them if they've talked to their doctor about that.
Okay. No, I haven't. Beth.
And then I would ask about the circumstances that tend to trigger that.
Okay. Every time I get up from bed, I have to stand for a few minutes. Otherwise, I feel like I'm going to pass out. Or if I stand for too long, it feels like I'm going to pass out.
Yeah, that's something I would definitely tell them that they need to follow up with their doctor about.
Are you going to treat them that day? Makes you think, right? How many
I
times?
don't think I've ever had that exact scenario.
Okay. What about
Well,
shortness of breath?
orthostatic hypotension, yeah.
Orthostatic hypotension. So are you going to treat that patient that day?
Probably, but I guess from what you're saying, should probably be monitoring blood pressure more frequently.
Right. So as a bare minimum, I would say, well, do you feel that now? Yeah, I do feel that a little bit now. Let's check the blood pressure, okay? Because we know the position changes, and if COVID, position change is a huge trigger for people. But for any of these things we talked about, low blood sugar, trauma, decreased blood pressure, and all these things, incidentally, are related to each other, right? So you could say low blood pressure could trigger an arrhythmia. I mean, low blood sugar can trigger an arrhythmia. So can low blood pressure. Arrhythmia could trigger low blood pressure. Arrhythmia could trigger a vasovagal reaction. A vasovagal reaction could trigger an arrhythmia, right? Anemia could cause any of these things. And so keep in mind that there's a lot to think about. And, I'm not saying this to like Rubik's Cube your mind and be like, it's just things to like say, well, there's a lot of possibilities here. And I know that sometimes when you don't know what's going on, or like, it's like if someone knocks on your door and says like, I think there's a killer in the hallway, you're kind of like, like you want to do something, but if you don't know what to do, at least call the police. Like you don't want to go out there yourself, at least call the police. But you said, Beth, you said, so did you talk to your doctor about that? So let's say, I'm going to pass it to Tom for a second. So Tom, patient comes to you for low back pain, right? You take their blood pressure and it's 100/60. Is that a concern to you?
It might not be at all. It depends on what their initial blood pressure was. Like that's.
So you
that's
mean the
my
first
wife's,
time you saw them?
my wife's
right?
normal blood pressure.
Okay, so you mean it depends what their blood pressure was the first time you saw them, right? Like what is their baseline, right?
Yes.
So now again, another question. How many people take the blood pressure every time they see a patient for the first time? Because you can get that 100/60, and you're right, trending is everything, right? So 100/60 may be perfectly normal, or it may be perfectly normal for, the patient on those medications, right? But if you've never checked it before and we have an emergency situation, then we don't know what's normal and what's abnormal for that patient. When you work in EMS, it's a lot different because it's not your emergency. You know what I mean? You roll up onto a scene, it's not my emergency. I don't feel the same, as crazy as it sounds, I don't feel the same pressure going to a cardiac arrest on an ambulance. I don't feel any pressure because it's not my emergency. This has nothing to do with me. But when things are going on in our clinic, it's our responsibility. And when you call a doctor and you say, hey, your patient's dizzy and their blood pressure is 100/60, and they say, well, what is it normally? And you go, I don't know. Right. And again, I'm not saying this to point fingers, that not at all. Okay. I just want to kind of get your mind thinking about different scenarios that, will help your patient. Trust me, you can save a life by being alert to things and having some kind of record, at least every, once a week, check a blood pressure, once check a heart rate, check a pulse, right? Or you check your patient's pulse. And if you've never gone over their cardiac history with them and they're irregular, well, irregular, maybe they're always irregular, right? There are people who are in stable atrial fibrillation that are well controlled, right? Their ventricular rate is well controlled. But if you don't have that baseline, and again, some people don't want that. Some people just want to come in and, oil the elbow or whatever it is. But to me, if you really want to excel at what you do, and you want your patient to walk out of there every time and be like, this guy was fucking great. Like you want them to go home and be like, this motherfucker over here, I've never seen something like that before. Like, it takes a little extra effort. And when a patient says to you, this is the most thorough exam I've ever had, then you're doing your job right. And then you get to teach everybody else. And then you get to teach your patients. And your patients tell everybody that, because then the patient goes back and tells their doctor. And when you send reports, like, Rob and Greg, I think I spoke to Greg about this. I didn't talk to Rob about this, but when we send letters, to our doctors, and it has all this stuff, and a doctor reads this and they're used to getting 5 lines because they just sent you, they're going to send you every patient they have. Right. And when I see patients, I send a letter to their internist, I send a letter to their cardiologist, and I send a letter to their pulmonologist, because I want those doctors to think of me when they have a patient who they don't know what to do with. And it's the same thing with the ortho. You catch something once, and you're going to be their therapy center forever. Any questions about neuro? All right. HEENT, head, eyes, ears, nose, throat. Do you get a lot of headaches? Okay. Headaches could be a lot of different things. What are some things it could be? It could be a brain tumor, right? It could be a stroke. It could be high blood pressure. It could be neck, cervical dysfunction. But again, if the answer is yes to that, then we should try to figure out what that is. In other words, is that an established problem, or is that something new? And that's another big kind of delineation between how much do you have to do something. So the answer is like a new onset of something. Like if you say, well, you know what, I sometimes get dizzy. It's been happening to me for years, blah, 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 blah. And this is what I do. I know how to handle it. That's different than if all of a sudden somebody's there and say, has this ever happened to you before? No, this has never happened to me before. That could be a myocardial infarction. That person could be going into cardiogenic shock. So again, really knowing their history and knowing how these different things behave is really important. Double vision or blurry vision, cataracts or glaucoma. Do you wear glasses or contacts? Okay, now that's a really important question. Okay, please make sure you look at the patient before you ask that question, because if they're wearing glasses and you ask them if they wear glasses, you've lost them. That's a wrap right there. Like in the same way you can impress them, if they're like, you've lost that patient. But again, the reason why I want to know these things is because I'm looking for changes. I'm looking for potential changes. Is your hearing okay? And that's when usually patients say, what, whatever. This is important because I need to know that when that patient's on the treadmill and I communicate with them, I want to make sure that I am speaking to them in a way that they're understanding my questions, right? I don't want them to misunderstand my question. And hey, guess what? They don't know what I'm asking them. They don't know when I ask them, are you working fairly light, somewhat hard, or hard? Is that important? And another thing is that, especially with older patients, they tend to lose the high tones, right? So rather than raising your voice and talking louder, lower your voice into a lower tone, and very often people can hear you better. Do you have any ringing in the ears? What about vertigo? And it's important to say, sometimes when patients don't know what something is, I'll ask them the same question in a number of different ways. So have you ever had vertigo? No. Does the room ever spin? Yes. Okay. Do you drink alcohol? No. Do you drink beer? Yes. Same kind of thing. Do you have any sinus trouble? Okay. The reason why I particularly want to know about sinus trouble is because that's going to affect how the breathing goes. So if I want to teach somebody to breathe in through their nose and out through their mouth, but their sinuses are constantly clogged, or they have a deviated septum, or they can't breathe in through their nose, then that's going to affect my treatment going forward. Same thing with secretion. Same thing with, that could be a headache. Do you have a sore throat or hoarse voice? Okay. Sore throat, hoarse voice could be a lot of different things. What are 3 things sore throat, hoarse voice could be?
Thyroid problem.
Thyroid problem. What else?
GERD.
COVID.
Crazy cat. Okay, so GERD, definitely. GERD is huge, and GERD is huge in COVID. Okay, for whatever reason, people have vicious reflux in COVID. And if you think about that, if it's bad enough, it comes up, esophagus and trachea very close together, can go up into the airways, right? Increased lung inflammation can go up into your throat, sore throat, hoarse voice, can go up into your sinuses if it's bad enough. And inflammation is something huge in COVID. What else? Sore throat, hoarse voice. Give me one more good one.
Well, sinus drainage.
Post-nasal drip could do it, right? So we want to know, is it going up or going down? Give me another good one. What?
Thrush, especially from medication, thrush.
Medications, right? So that's a big one. Marion said thrush. So thrush is candida, right? So it's a fungal infection that people get often from, taking inhaled corticosteroids. So if your patients are taking those, then we want to make sure that they're really rinsing their mouth and spitting, gargling and spitting to make sure that that medication doesn't stay there. Dentures. Do you have dentures? How many people ask if their patients have dentures? I do. You know why? Because if God forbid I have to do CPR or give compressions or try to, give somebody rescue breaths, I don't want to push their dentures into their trachea, right? So these are little things that, and it sounds morbid, right? It sounds crazy, and you're like, this guy's crazy, but it could happen. And I say these things because it's just a little note, a little mental note that you can make to yourself. And I just, I believe in being prepared for as many things as possible. Speaking of dentures, I used to have this series called Dinner and the Doctor at Boulay. David Boulay is a famous chef. He's big on healthy, creating super health. And there was a lady that I could tell her dentures were loose the entire night. I could tell she was struggling it, and then as she was saying goodbye to me, sure enough, came out of her mouth. Because I was aware, I caught her denture and was able to give it right back to her. But the idea is be aware for as many things as possible. Expect the unexpected. Pulmonary, very important. Have you ever been told you have asthma, right? Just because you haven't been told you have asthma doesn't mean you don't have asthma. And some people think they have asthma or have even been diagnosed with asthma, and they don't. They have other pulmonary conditions. Have you ever been told you have COPD? You know what most patients say when you ask them that? What's COPD, right? So if we sometimes run through things and say, no, I've never been told it. Have you ever been told you look like a clown? Yeah, I have. But if you haven't necessarily been asked that, you want to ask things, especially things that are confusing, in as many ways as possible to make sure the patient gets it. So say, have you ever been told you have COPD? What about emphysema? So a patient will say, no, I don't have COPD. Do you have emphysema? Yes. If you have emphysema, you have COPD. If you have chronic bronchitis, you have COPD. You could have COPD and not have chronic bronchitis if you just have emphysema. And you could have emphysema and you could have COPD and not have emphysema if you just have chronic bronchitis. But it's really important to speak and make sure that the patients know what we're talking about. Have you ever had pneumonia before? Okay, that's important because it tells us, number one, are their lungs a problem? Are they prone to infection? Are they going to, and I want to know, have you ever been intubated, right? So have you ever been hospitalized for pneumonia? No, I had walking pneumonia. I treated at home. Have you ever been intubated before? Because a patient who's been intubated before tells us that there's a chance that this patient will be more likely to be intubated again. Are you coughing, right? How many people ask about coughing? I mean, it may not be applicable. A patient comes in and says shoulder pain, you don't have to ask about coughing. But with COVID, you should be asking about coughing, okay? People are coming in from all over the place. I want to ask questions. I want to be safe, not sorry. And then it's another kind of decision tree. Are you coughing? Yes or no? Okay. No, great. Okay. No cough. Yes. Okay. Then we have other questions to ask. So if you're coughing, are you bringing up mucus? Another way to say, is it a productive cough? Is it productive or dry? Okay. If it's a dry cough, it leads us to so we say, is it productive? Are you able to bring up any mucus? If the answer is yes, then we want to know, is it thick or thin? Is it clear, white, or colored, right? Because we know that the thicker something is, the worse it is, the less chance they have of clearing it, the increased chance of infection. Colors, right? We want things to be clear or white. Yellow and green typically indicate infection. Red can indicate blood or they had the Jell-O for lunch. Other things If somebody's not bringing up mucus, then I want to know, is it that you don't have the mucus, or is it that you have the mucus, but you just can't bring it up? Because the cough mechanism is really only effective from here up, which means that if you have a lot of mucus down here, you could cough till the cows come home and not bring up that mucus. And that means that you are more prone to infection. So if you think about the patient that says, you know what, I cough when I lie down, right? What's the solution for that for a lot of patients? They don't lie down.
Sitting up position.
So they sleep on a wedge, or they sleep in a recliner or something like that. But if you think about the fact that I just told you that unless they get the mucus to here, it's not coming up. Well, guess what? That may be preventing them from coughing, but it's not helping them with respect to clearing secretions and preventing infections. Shortness of breath, dyspnea on exertion. So dyspnea on exertion versus dyspnea at rest. A lot of patients with COVID are reporting shortness of breath at rest that's totally disproportionate to any activity that they're doing. Are you wheezing? And then occupational exposure. So I'll ask that, do you work? What do you do? Have you ever had any exposure to heavy dust or chemicals? Because those things don't always happen. You know, the signs and symptoms of that don't always occur at the time that the patient is working in the factory. But if you find out, you know, hey, 40 years ago, I worked in a factory 40 hours a week for 5 years and there were no regulations at the time, or I worked in a coal mine, that stuff can come back later on, or as we lose natural lung function over time, that, you know, dysfunction can show itself. Cardiac, any questions about pulmonary? Cardiac. So do you have any chest pain or pressure? And this is another one where I'll ask this question a million different ways. Do you have any chest pain or pressure? Do you have any squeezing feelings in your chest? Okay, I'll make this signal. This is called Levine sign, right? So when somebody goes like this, that's a diagnostic. It's almost like a special test for the heart, okay? If somebody does this, that's how the heart behaves. If somebody points and says it's sharp right here, that's not how the heart behaves. So do you have any chest pain or pressure? Do you have any squeezing feelings in your chest? And then if they say, yes, I do, right? Like that could be airway inflammation, right? Like if we have asthma and we go out in the cold and it squeezes our airways, that can make you feel like you're short of breath. That can increase the pressure in your chest. A lot of patients with COVID report that. Somebody with a kyphoscoliosis could report, you know, shortness of breath or squeezing in their chest or pressure in their chest, especially when they become more active and they need that bigger breath, but it's not there because their musculoskeletal system doesn't allow them to expand that far. Other things. So again, onset, okay? When does it occur? Or what were you doing when this occurred? P is provocation and palliation. So what makes it worse? What makes it better? It gets worse with activity. It gets better with rest. It gets worse when I have an argument with my husband. It gets better when we calm down and we make up. It gets worse when I walk up the stairs or when I'm under stress. It gets better when I'm on vacation. Q, quality, again, sharp, dull, squeezing, pinching, pressing. Those things are all telling as to what the source of the discomfort is. R, radiation. So is it something that is here, left-sided substernal chest pain, or does it radiate down the left arm? Does it radiate under the axilla? Does it radiate around to the shoulder blade? Does it radiate to the neck or the jaw? Right? So a lot of times people have something and you say, well, you know, if they're walking, they say, you know what, I'm getting a tightness in my back or under my shoulder blades, and it happens at high levels of exertion, but then it goes away as we cool off the activity. That's something that you need to think about. Those are atypical, you know, signs of angina or heart disease or ischemia, or they are what we call like anginal equivalents. And another thing about the heart is that I'll ask people, when you get this discomfort, does it come on like a light and then go off like a light? In other words, it's there, then it's gone, or does it sort of ramp up and become worse as you become more active, and then it kind of ramps down and goes away as you sit and rest? Because the heart doesn't be like, oh, you know, someone will be like, oh, it just lasted for a second. The heart doesn't last forever. The heart will ramp up and sort of like elevate and elevate, and then it'll cool back down. So all these different things are little tips that you can ask your patient to kind of help you further delineate what's going on there. S is severity. So, you know, again, things like, you know, when we talked a little bit last week about stable versus unstable. So, and I know we're running short on time. Are you guys good for like 10 more minutes? I mean, if you're not, you can hang up. This is being recorded, so I have this one. But you know, when it comes to things like severity, so a lot of people have stable chest pain or stable angina, right? It goes up to level 4 out of 10 when I climb the stairs, and then I stop and it goes away. Or it goes up to level 4 out of 10, I take a nitro, it goes away. If all of a sudden this week you're at level 7 out of 10, unstable angina, or if it used to come on with 2 flights of stairs, and now it's coming on with 1 flight of stairs, that's unstable angina. If it's more severe, it's unstable angina. If it's a first onset, unstable angina. So first onsets of things are often emergent when they might not always be emergent in the past. So if we know somebody usually has a normal sinus rhythm, and today's the first day, hey, you're an AFib today, that's an emergency. That's a trip to the ER, because AFib can cause a lot of secondary problems like blood clots, like stroke. So at a minimum, we want that patient to go in. We want to make sure their ventricular rate is controlled, and we want to make sure that they're anticoagulated so that they don't wind up with a secondary problem related to that. Other things, timing. So is it constant? Is it intermittent? Is it, you know, happens more at night, happens more in the morning? All these things tell us different things. And then I is intervention. What do you do for it? So I take some nitro, I take my bronchodilator, et cetera, et cetera, et cetera. And then I'll just ask questions. So orthopnea, right? Like, how many people think that your grandparents would know what orthopnea is, right? Probably nobody. So you say, are you able to lie flat in bed? And I learned this from my own doctor, Murray Berenson, who was a super genius of diagnosis. I learned more from my first visit with this doctor than I probably learned in a year of school. When you lie in bed, are you able to lie flat? If they say, no, I can't lie flat because I get short of breath. I can't lie flat because I cough. I can't lie flat because I get reflux. These are all different things that can happen, and simply avoiding the activity may cause you to eliminate or avoid the symptoms, but it doesn't take away the problem. So if every time somebody goes to sleep and a couple of hours later they wake up short of breath, which is PND, paroxysmal nocturnal dyspnea, then that should make us think, hey, this person's got a fluid issue, and they're lying down, and an hour after they're going to bed, guess what? Their left ventricle is starting to get tired. And they get up and they go to the window and they open it up and they feel better. These are things that, you know, are not often asked. Do your feet swell? Okay. And there's a difference between one-sided foot swelling and two-sided foot swelling. So two-sided, think systemic. One-sided could be musculoskeletal, orthopedic, or clots. Another thing, if a patient comes in, it's worthwhile checking pedal pulses the first time you see them, especially if it's a vascular patient or a cardiac patient or somebody who might be prone to clots. Because if they come in and let's say their leg is double the size and it's cold and it's pale, then you want to have something to compare that to. If nothing else, you can check back in your notes and say, well, this person had weak pedal pulses, and we know it's not the first time we're seeing it. Have you ever been told you have coronary artery disease, atherosclerosis, heart disease? Have you ever been told you have congestive heart failure? Have you ever had a heart attack? I'll let you in on a little funny joke. Every patient loves it. After you ask them if they've ever had a heart attack, ask them if they've ever given anyone a heart attack. That one's a killer, goes over great every time. High blood pressure, high cholesterol, pulmonary hypertension. Most people don't know what it is, but it's worth asking. If you have it, you know what it is. But if you know what it is, you have it. But not everybody who has it knows they have it. And have you ever been told you have any type of arrhythmias? And the most common one we'll see is atrial fibrillation. Any questions about the heart? And I know that's a quick run through. We'll go through that at a later time.
No, can I just mention one more thing?
Yeah.
For women, postmenopausal women who complain about night sweats and or not hot flashes at night can be cardiac. So if you have somebody who's way past menopause, but talks about hot flashes at night, you might want to sort of investigate.
And also, if someone's past menopause, we want to know, are they on hormone replacement, right? Because we know that men typically lead women in heart trouble until menopause, and then women actually surpass men. But it makes you wonder why they call it menopause. I just thought of that now. I'm going to leave that one for you guys to think about till next week. Any other questions about the heart? Okay, and we'll go over more like EKGs and things like that. Stomach problem. Do you have any stomach problems? Have you lost or gained any weight? Lost or gained any weight is important for a number of reasons. We know that it can affect the orthopedic system. It can affect the cardiac system. It can affect shortness of breath in the respiratory system. We know that weight can not only affect different systems, but be affected by other systems, right? So if somebody's got a bad hip that doesn't allow them to exercise, and they're used to, being very, very active, and then they have a hip fracture, they may put on weight. If they have heart failure, they may put on weight. If they went and had the locks at Katz's Deli or something like that. I had a patient one year, he had heart surgery, went right from NYU Hospital to Katz's Deli, and had like a half a pound of locks, was back in the hospital a couple of days later with a 20-pound weight gain. And weight loss. Like if you think about, hypermetabolic states, like where somebody's short of breath, or they're in pain and they're working very hard to breathe, or their everyday activities are more metabolic, that could cause difficulty in them maintaining weight. And after they lose their fat, they're going to lose muscle. And that's a serious problem. Any other stomach issues? And I don't necessarily go into nausea, vomiting, diarrhea. I don't necessarily want to, I'll go into it if the patient starts with it, but I'm not a proctologist. I don't have to go through everything, but those things also can have a huge impact. If you think about somebody who's had diarrhea, right? If someone comes in and says, I've had diarrhea for 3 days, think about the impact on fluid, think about the impact on electrolytes, right? So they could have a total loss of fluids. Their pressure could be lower. That could cause arrhythmia. Electrolytes could be off. That could cause arrhythmia. Somebody could say, you know what, I haven't gone to the bathroom in a week. Guess what? That increased intra-abdominal pressure can be pushing up against their diaphragm. It can make it more difficult for them to breathe. It can also increase their blood pressure, okay? Because there's increased intra-abdominal pressure. Increased pressure in the abdomen will increase thoracic pressure, and vice versa. So like if you think about it like a suitcase, one is abdominal contents, one is thoracic content. If you overstuff one side, it's going to encroach on the other side. Reflux, again, I can't tell you how important that is, especially because reflux can appear to be other things, and other things can appear to be reflux. Do you have any urinary problems? Okay. Polyuria is I go to the bathroom a lot. Incontinence is obvious. Are you on a diuretic? Okay, that's important to know too. Do you have any vascular or circulation problems? And again, I usually leave it at that unless somebody says, well, what's that? Do you have any cramping in your legs when you walk for a long time? Things of that nature. Do you have any blood disorders? Do you have any thyroid trouble? Are you diabetic? Osteoporosis? Do you have any skin problems? Do you have any musculoskeletal problems? Joint swelling, stiffness, pain, arthritis? Are you depressed? Are you anxious? And again, like what I just did where musculoskeletal is like one tiny piece of that, maybe for you, that's this, and this other stuff is a tiny piece of it. But the thing is that even though I may not be treating the patient primarily for orthopedics, I'm at least going to want to know about their orthopedic status, because that will potentially impact my cardiopulmonary treatment. And I think that's a good place to stop. Questions, comments, feedback?
I have a question. So when it comes to, say, vomiting or diarrhea, as an example, when it started, I mean, when do you get into the detail? I mean, everybody's had diarrhea in their life, type of thing. Are you looking for current and knowing the differences between current symptoms? What are you experiencing now versus a chronic problems, say like incontinence would be more of a long-standing thing.
Right. So like if they're experiencing diarrhea while you're asking the question, send them immediately to the bathroom.
Yeah, right.
No, but
Exactly.
you know, there's a difference between, so again, that's something that, like, you know, there are patients like, let's say with Crohn's disease, there are patients with ulcerative colitis, there are patients with IBS who are going to have chronic diarrhea, right? Or chronic constipation, or alternating diarrhea for a week and then they're constipated for a week. And when you catch them, could potentially affect their blood pressure, could potentially affect their breathing, could potentially affect other things. And so if that's your patient and they have uncontrolled, you know, inflammatory bowel disease, well, that's going to affect your treatment no matter what you're doing, because you may catch them on a week where they're going to the bathroom 30, 40, 50 times a day. They can't leave the house, right? And likewise, you know, like if somebody comes in and they say, you know what, I ate something bad for dinner the other night, you want to kind of delineate between chronic versus acute. So if someone comes in and they say, you know what, I ate some fish last night, I've been throwing up and I've had diarrhea all night. Well, you know, you want to check blood pressure, you want to check oxygen, you want to check, you know, heart rate and rhythm, but you also want to take into consideration that if you were planning on having them get up onto that balance ball or balance board, or having them lean back over that, you know, ball, that is going to have an impact on your treatment for that day. Or like if you take their blood pressure and they're normally 120 over 80, but today they're 90 over 60, well, guess what? That may not be the right day for treatment, because on any other day they might have been perfectly fine, but today, because of that electrolyte imbalance, they may be prone to a cardiac arrhythmia that they wouldn't have had on any other day. So maybe that's the day to say, okay, well, let's hydrate you. Let's give you some electrolytes. Let's give you some fluids, and see if your pressure comes up. And sometimes if somebody comes in, sometimes a patient will come in, say, you know what, or, you know, I just got in from drinking, or they say, you know what, sometimes somebody comes in, you smell it on them, right? You know, they've been drinking. And they say, no, but I'm okay. Okay. So if they say they're okay and something happens during your treatment, and then the patient gets taken to the hospital and their blood alcohol level is, you know, 0.9, they're going to say, didn't you know this guy was drunk? You know, so these are just things to consider. So if it's somebody acute, like somebody doesn't usually have diarrhea, it's never been an issue before, but you know what? 2 days ago, they ate the fish at, you know, Charlie's Seafood Shack, and it was 2 days too old. So, you know, now they've had 2 days of losing fluids. They've been in bed. They're starting to feel better, but maybe you know, maybe their blood pressure is 40 points lower. And so because their blood pressure is 40 points lower, that could trigger orthostatic hypotension, right? That orthostatic hypotension could trigger an arrhythmia. Or if they have risk factors for coronary disease, then that person could have an MI when they wouldn't have normally had an MI that day, but all the things kind of lined up against their favor.
Thank you.
Other questions, comments?
How long does that systems review usually take you with the patient?
Do you have any neurologic problems? Have you ever passed out, dizziness, stroke, seizure? Do you ever get a lot of headaches? Do you have double vision, blurry vision, cataracts, glaucoma? It's going to take as long or as short as many things as the patient has. So for example, with COVID, like sometimes it could take an hour, sometimes it could take an hour and a half, because we don't want to miss stuff, right? And that's tricky. Like one of the things I've always loved about H&D, and one of the reasons why I've always sent my patients, is because I know patients get an hour of care, one-to-one care, right? It's not like 10 minutes of you have me for 10 minutes and then you're going to share me with these 5 other people. But you know, the initial evaluation is the most important visit that you're going to, in my opinion, that you're going to see the patient, because that's your opportunity to learn everything, to get all this information, put it in perspective, and develop your hypothesis and develop your treatment plan. If you get it wrong, not to say you can't reassess and reevaluate. We all make mistakes. Sometimes we think something, we're 100% wrong with something totally different than what we thought. And that happens. But during this time, if you skim over something or you skimp on time because you have another patient coming, that's why, you know, I usually set aside an hour and a half for new patients, because I want to give them the opportunity. And then at the end of all this, you know, say, is there anything that I missed? And then I repeat back to them everything that they told me. And I say, I just want to make sure I understand everything. So your biggest problem is your shortness of breath, started 3 years ago, getting worse over time. Now it's this, this, and this. Is there anything that I missed? Because there's a lot of moments, especially patients come in, they're anxious, they're in a new place. COVID makes everybody crazy. And a lot of times people, oh yeah, I forgot to tell you one thing. And that one thing may be like, you know, oh yeah, and a lot of times someone will tell you something after the treatment, right? Like you ever have that? Like we had that today. Someone said, oh, you know what? I got super nauseous. When did that happen? While I was on the treadmill. Why didn't you tell us? You know, so it's important to keep checking in. And same thing, you know, sometimes one therapist, this is where communication comes in. Therapist will ask somebody a question. No, I don't take any medication. No, I have no medical history. Excuse me. Someone else comes in and says, yeah, I've been a diabetic since childhood. Or like, you know, see a patient, pick them up. No, I don't take any medication. Get them to the ER. Nurse says, do you take any medication? Yeah, I have a list in my pocket. It happens. That's why you have to keep asking the same things in different ways, coming at it at different angles, because ultimately we're the captain of that treatment ship. And what happens on that ship is our responsibility. And that's individually and as a practice. So Rob and Greg own the practice, but you're responsible for, you know, he's not inspecting every cabin, right? You each have your own cabin that you're responsible for. And if something happens on the Fiesta deck when you were supposed to be watching it, you know, then that's on you. We don't want to be the one that is responsible for something going wrong with our patient. Again, you know, we could do everything right. You get the wrong patient on the wrong day, things can go wrong. It's just a fact of life. We can't do everything right every single time. But sometimes you do something wrong, you get lucky, and sometimes you do everything right and you get unlucky. But my systems review can take me, as long as it's not like a straightforward patient, could take me 15 minutes to get through this whole thing or less. And then there's the patient who the answer to the questions will be no, but then they want to explain to you why it's no. That's a long eval. So that's a really long eval. That's usually like a good 3-4 hour eval. Do you have any shortness of breath? Nope, I never had any shortness of breath. My cousin Becky, she had shortness of breath, but me, nope. I've always had good. And then that's one by, and then you have to say something like, listen, keep it yes or no. Unless the answer is yes, then let's go further. But yeah, I mean, and again, it's the more you practice it, the better you get at it, and the more second nature it gets. You know, again, in the same way, we don't want a patient, you know, learning how to use their rescue inhaler when they're in trouble. Like, we don't want to learn how to perform a procedure when we're actually doing it for the first time. Like, when I'm recerting my EMS now, like, you know, I practice these things, and I, like, all of a sudden I'll say, what happened if this happens here? I don't want to get to a scene and be like, oh, what was that again? You know, and I've seen it happen. Like, I've seen it happen to people where they don't know what to do, and they say, do you want to take care of my patient? You know, but the more you do it, the better you get at it. And this is like a lab, you know what I mean? It's like a lab. It's like you learn something and then you take it to the lab, and then you're going to learn it yourself. Like when I was at NYU, I became the chief when I was 24, totally unprepared for the position. Bill Kuntz left unexpectedly, and I became the chief. They told me to apply. I was shocked, got the job. Everyone in the medical center was like, what? And I was like, that's right. I told you, bitches. But you know, the idea was I was super light for the position. But what I did was every month I went to another facility and I watched and I learned and I asked questions. And then I come back and I try this in the lab with my patients. And you say, well, this is what they're doing at Duke. We could do this here. This is what they're doing at UCLA. We could do this here. This is what they're doing at the University of Florida. We could do this here. But when you hear these things, don't expect to get this all right tomorrow, right? But just start with one aspect of it. Just ask one set of questions that you haven't asked before. And when you get it good at those, then start asking another set of questions. And if you want to go in priority order, and with my COVID patients, what I do heart, neuro, lungs, abdominal. That's my order, because I go from life threats to inconveniences. And you could do that too. The heart stuff, that's where I'd start if I were. Do you ever get any chest pain or pressure, right? Because how many times does somebody have back spasm and it could feel like chest pain, or they have heart trouble and it feels like, musculoskeletal. And a lot of times we'll say, is it musculoskeletal? And a lot of times something will be dismissed as musculoskeletal and it's really cardiac, or something will be told as I always will treat as cardiac until proven otherwise. But you don't necessarily want to run somebody to the emergency room when they have a tight intercostal, which you can palpate and reproduce the discomfort. So, again, this is 30 years of my work to come up with 2 pages. You know what I mean? So the idea is I don't expect you to get this, but again, you just saw how many possible reasons there are for syncope, and just start with the medication. Let's put up a list in the clinic. Let's put up a big list and get all the medications there. And when you go and you see the list, if the medications from that patient are already on there, don't put it on. And in 2 weeks, if all of us do that, we'll have the H&D list of most commonly used medications. And that's 25 medications to remember instead of 2,500. Want to do another hour? No. All right. So I think that's it. I mean, anyone have any other questions or comments? I would encourage you, this was a lot, like the system review was a lot, but I'm glad because we at least covered everything, at least on a global scale. So think about this as you start seeing your patients again this week. And even if they're patients you've known for a while, just ask them the cardiac and the pulmonary systems review. And you'd be surprised how many of your patients that came in for a purely orthopedic condition sometimes get chest pain or pressure, or sometimes get shortness of breath. That would be an interesting kind of study, an interesting experiment to find out. And again, what?
I was just going to say, just the observations of your evals. When you hear people tell their story, it just, what I've typically just kept it 2-dimensional. They fill out the medical history form on intake Q, and it's 15 pages, and they have yes and no's, and I usually just kind of disregard it. But when you actually take the time and ask these people these questions, the stories you get, and it just brings it 3-dimensionally and much more of a systems approach that is a big eye opener for me.
And also a much more humanistic approach, right? Because up here, when we look at this in black and white, it's just signs and symptoms, right? But if you think of a patient and that patient goes, and bam, there it was, right in my head, throbbing. You learn these patients and you remember stuff, right? How much does it suck when a patient says, I told you that already, right? And that weakens the patient's confidence in you, right? But don't you listen when I talk? Don't you remember when you listen, or things like that? So, again, it's paper is one thing. The patient is, that's why listen, if this really meant something, then the people who do the reviews for insurance companies would if it really understood how it goes, like they could look at this, they don't know what we're talking about. It's like we got auditor, we say, this is in Chinese. You don't speak Chinese. Why are we talking to you? You guys don't understand what we're talking about, but they're making decisions on our care based on this, right? So it's really important. And again, the more you know your patient, the more you remember, it just seals that bond, it just seals that bond. And, it's a different kind of, it takes on, your practice takes on a different kind of, and I'm sure many of you know exactly what I'm talking about and have experienced it. Like I said, when I talk to you guys, I'm not talking down or saying, I know you guys don't know. I mean, I have a lot of respect for your team. If not, we wouldn't have come to H&D. We don't want to be in some, Kentucky Fried Chicken of physical therapy, So it's like, but the idea is, that can become your everyday. That can become your everyday of people saying, thank you so much. You've helped me so much. Like every day I get 25 letters or cards or gifts from people, that just say, thank you, if not for you, this, and I'm not saying that's why I do it. I don't care about that, but it's nice to know, hey, guess what? If I didn't take this guy's blood pressure, nobody would have known this. And maybe he would have gone home and fallen in the shower and died. We've had patients who, decide to change a light bulb on like a spinning stool. So, you know, the more you get to know a patient, you know, to me, I love being able to participate in a person's life at the time that they need it most. That's a very valuable gift. You know, that's a very valuable gift to be given. And no disrespect to anybody, but it's a lot different than making the best mocha latte. You know, I mean, it's patients come to you when they're in trouble. They come to you when they're scared, when they're sick, when they're hurt, and we get to turn their lives around. Very often that happens when other people have told them there's no help for them or there's nothing more we can do for you. And a lot of times it's just making the effort and going that extra mile and, you know, being willing to put your own ass on the line and participate, you know, and be part of it. You know, I'll just end on this one quote that I love that Dr. Pineda also used to say. He'd say, some people make things happen. Some people wait for things to happen. Some people make things happen. And some people say, what happened, you know? And it's like, you know, it's really, you know, you decide what kind of career you want. You know, we all make those choices. And for me, it's a very, you know, I hope it's obvious, but it's not a job to me. I mean, it's a super calling. I've been given a gift. I can help people breathe better. I can, you know, I can participate in their lives in a way that not many people get that opportunity. And it's a very, very valuable thing. And it increases your chance of winding up in heaven. So cardiac systems review, pulmonary systems review, medications. Those would be the big three takeaways for me from tonight. So, and if you guys have questions, Marion and I are always available. You know, if we're not available that second, we'll always make time for you. So please utilize our time there. We want to help you. We want to help this practice grow. And, you know, we want to, anything that we participate in, we want it to be as great as possible. And you guys do run a great practice. But there's, you know, everything can be improved upon. You know, everything can be improved upon. And I think these little things and these little tweaks, these little attention to detail, it's like when you go to your hotel room and they've made your towel into the shape of a swan, you're like, that's nice, you know? You want to give a little extra tip at the end. So keep these things in mind. We're here. It's not something that, you know, we expect you to get in one shot or even 100 shots. It takes practice. But again, if you have any chest pain or pressure, palpitations, when you lie in bed at night, do you ever get short of breath? Do your feet swell? Have you ever been told you have coronary disease, heart failure, MI? Those three things you're going to learn about your patients. And that may also be the key to why some of their orthopedic and musculoskeletal stuff is not as successful as it could be, right? Because maybe they're having other issues that we don't know about. I'll shut up now. So I could keep going, but see you next Monday. And I'll see some of you guys tomorrow. So have a good night, everybody. Thanks for your attention.
Thank you, Noah.
Thank you.
Better begins here.
Absolutely. BBH.
All right.
All right. Have a good night, everybody.
Have a good night. Good night.